the overall medical status of the child and the dental status, the appearance. Also took an interest in the psychological and social well-being, the hearing and speech, etc., etc. Now, the treatment of these patients generally requires multiple visits to the clinic. This, except of course, if it's done in an outreach where you may never even see the child, but that is not ideal. And so in the ideal situation, these children and their parents lose a lot of time traveling back and forth to the clinic. So they lose time from work and school, seeing different specialists. Now, this burden of care can be minimized a great deal if the health experts work as a team, provide comprehensive care. Many of these children can't speak, and the hearing is also bad, and people see them and look at them and say, this is a retarded person. They struggle to make friends, and they generally have a low self-esteem and go through their entire lives looking very sad. Everything about them gets delayed, and they struggle to start a family. Generally, it's been estimated that those born with cleft lip and palate die about 14 years earlier than others. My slides are not advancing. Is there a reason for that, Esther?
No reason they should not be advancing.
Stuck on that slide. So, oh, here. Okay, so this is, oh, okay, all right. Typical family, possibly with a cleft, traveling from out of town to a clinic. This is a transport they need, and sometimes with breakdowns, and it's a real struggle to come and see us. Still, I think it's, you think it's network? I shouldn't be able to speak if it's network. It's not advancing still. What's going on? These technologies. So, oh yeah. Sorry, folks.
Hi, Peter.
Yes, yes, Philip.
Maybe for a second, try on sharing your screen and see if it advances.
Try on sharing. Let's see. Okay, let me see that. So stop sharing, you think?
Just try for a second, see if it advances, then we'll see how we can take it from there.
These technologies are...
Well, it has advanced for us.
Yeah, great. So now, so this is a child with clefts, and obviously this is not how the mother who carried him for 9 months expected to see when the child was born. The appearance is not as expected. Go to school and get bullied, be teased. Some cases they're even rejected from their maternal, from their family homes, and they are branded as witches, and this may lead to family conflicts. We've had cases where even the father tells the mother, take this child away. Where does it come from? And then they have dental problems and orthodontic problems. So you can see here, even the gum, there's a gap in the gum. And then this part of the jaw, that's where the cleft is not developed as much as this side. So it's collapsed. And so when the teeth develop and they grow on this side, the teeth will be out of alignment. In this particular child's case, the cleft is on both sides. And apart from the gap, where also there were no teeth erupting, this front part is the premaxilla is actually projected outwards and compounding the deformity. These children are not like they are not different from other children. They're also prone to develop tooth decay and gum infections. So they have dental and orthodontic problems. They may also have associated syndromes with like this craniofacial case with abnormalities involving the eyes, the head, the nose, and definitely the parents think it's a monster. And this child here, you can see the abnormality of the limbs. Abnormalities may affect other organs as well, kidneys, the heart. They tend to get recurrent ear infections and therefore get hearing loss. Now, when the child has a cleft palate, they are not able to suckle, and so breastfeeding becomes problematic. What they eat often comes out through the nose, and while they're feeding, they're taking a lot of air, which makes them feel full earlier, so they are not taking adequate amounts. As they get into making sounds, the speech does not come out well. So they have abnormal speech development. So this complex pathology requires that more than one expert looks after these patients. And so team care, as it's called, kind of health payment system and this health system in general and the cultural factors that prevail in a community affect the ability to establish a multidisciplinary service. My program is back, but it's not advancing again, but I'll see what I can do now. Yeah, so now a typical team will include a medical practitioner, a medical professional, which could be a pediatrician or primary care, like a family physician, a surgical practitioner, a speech therapist, maybe a psychologist and or social worker, and dental professionals. There could be other professionals as the need arises. Now, typically, two systems tend to prevail. In one system, the patient is seen by maybe the initial caregiver, and then they make their own assessments and then refer them to another practitioner to also do the assessment. So they drop the treatment plans individually. It can even happen in the same facility where they struggle to find a common time to meet. So, okay, you see the patient and then send them to come and see me. Now, in the other situation, which is considered ideal, then these experts put time aside and actually meet around the patient. So they are all there. They develop, they assess the patient at the same time. They agree on the diagnosis, drive a treatment plan, and they also even learn from each other. They see how a pediatrician assesses a cleft child. Pediatrician also learns what the surgeon does. And they also understand how the speech person also works around it and how the nutritionist also goes about advising these patients. And in either case, apart from the clinics, time must be put aside to discuss the patients. Very important. And in order for these teams to function harmoniously, there should be clear roles play. Everyone should have their job clearly cut out for them because they have legal accountability for the advice they give to the patient. A surgeon cannot be responsible for the advice a speech therapist gives, and vice versa. There should be respect for the expertise of the team members. That's not to say that you mustn't listen to what your colleagues say. The team leader should be recognized and should be fair to all, including the family members, and he should assume responsibility for the function of the team. Now, sometimes there are interprofessional conflicts. For instance, in the surgical disciplines, there could be turf wars, surgeons fighting over who has the right to do what, and so on and so forth. And so these disputes must be recognized and dealt with expeditiously and sensitively. But ultimately, the resolution of some of these conflicts, it should be guided by the need for ensure quality of care. So any practitioner who wants to be part of on this team justifies the inclusion by providing quality care. In our sub-region, we have not too many teams are in place. And it's because many of our teams came about because of surgery. So patient as a whole, surgeon repairs it, and then that's the end of it. Smile Train came on board and made funding available for us. So most of the time, the funding initially was for surgery alone. So that's how it came about. It was a lot of lifts and pallets were being repaired, but beyond that, it was not much was being done in terms of other services. And so most of these teams have become surgery dominated. And the composition is being determined by who is available, who's around. Now, it's nice to know that Smile Train is actually now looking to expanding multidisciplinary care and in many places support multidisciplinary care actively in many centers. So the American Cleft Palate Association set up a committee to look at who the team members of a multidisciplinary team are, and they came out with this list. These lists are never comprehensive enough because new teams keep coming, and new specialties keep coming, new needs arise, and so on and so forth. So you have an orthodontist, pediatrician or primary care physician, speech therapist, surgeon, nutritionist, psychologist, social worker. They don't have to be one and the same person. They can be separate. You have an audiologist, ENT, geneticist, and the parent and child are considered to be an essential member of the team. Anesthesiologists, nurses, a data manager, a coordinator or secretary. But there will be local variations depending on who is available and how the team started. Now, we were lucky yesterday to listen to Professor Adebola, who took us through, gave us an overview of cleft lip and palate. This is just to show you about a sample treatment sequence. It's not cast in stone. Different centers have different approaches to cleft lip and palate care, but by and large, most people repair the lip at 3 months. But for the newborn, is usually assessed, and there's general counseling of the parents, and feeding instructions are given, and determination made whether they need a feeding plate or an obturator to help them feed. Orthodontist may or may not do some procedures on them, and the geneticist may, if there's one available, may do an assessment of the risk of cleft in the family. But various interventions occur at different times, but as I said, these are not cast in stones, but stone. So we have speech evaluation, cleft palate repair, orthodontic treatment, and speech therapy also starting, available bone grafting, orthodontic treatment continuing. Orthodontic treatment seems to continue throughout most of their life. And then they may have surgery on their jaws if there's still residual abnormality. Oh, this is, sorry, I have to keep doing this. Otherwise I miss it. Yeah. Now, so what does the pediatrician do? Responsible for physical examination of the patient and assessing the patient's overall health status, monitors the growth and developmental milestones. The geneticist, if you have one, will look out for syndromes that may be associated and determine if there's a genetic basis for the anomaly and provide genetic counseling as regards relative risk to future offspring and other family members. The orthodontist is an expert in growth and development of the facial skeleton and will do an overall assessment of using various measures like radiographs, study models, and so on and so forth, and determine whether there's a need for early intervention. If there's crookedness of the teeth or malocclusion, they will correct them, and they work with the surgeons to prepare the child for bone grafting and later for orthodontic surgery. Now, if there's no orthodontist, there may be a general dentist who's helping the clinic. They may be helpful in providing preventive dental care and dealing with other dental problems as they emerge, like dental caries, gum infections, and delayed tooth eruption. Nutritionists, not all centers have nutritionists, but if they're available, they are very helpful in advising on feeding, both with breastfeeding and also in the absence of breastfeeding, on alternative feeds, and then also they help to monitor the feeding and the weight gain. The speech pathologist or speech therapist, as it's called some places, really monitors speech output, and as the need arises, also offers therapeutic options to enhance speech, improve speech, especially if there's a problem with the speech. By and large, though, real therapy does not start until the child is able to cooperate with the therapist, which is around about the age of 3 years. But they will do their evaluation of the condition before. Sorry. Now, surgeons cannot do without talking about them. They are there, and it depends on the center. You may have an OMFS, oral maxillofacial surgeon, ENT, plastic or pediatric surgery, or other surgeons, alone or in combination. Now, the bottom line is that the surgeon on the team must be capable of repairing the defect, or if they are not able to do all the surgical interventions that are required, they should also be able to liaise with other surgeons or bring other surgeons onto the team. And the role of the surgeon includes knowing when to repair lip and palate, harvesting bone to close defects of the maxillary dental alveolus, and then doing a nasopharyngoscopy to examine the speech mechanism, and then performing pharyngoplasty if there's a need for to improve the velopharyngeal function, correcting residual nasal deformities, and then performing corrective orthognathic surgery. This is an area that is, I mean, you don't have, there are not many centers where the surgeons are able to do all these procedures. And it's something that we could probably discuss further. No, this is not advanced. So anesthesiologists, of course, what can we do without them? Without them, surgery can never happen. They evaluate the patient's fitness for surgery and provide safe anesthesia and intensive care as needed. They help with postoperative pain management and liaise with the surgeon in planning further surgery. Social workers are invaluable. They are patients' advocates. They refer families to persons or agencies for guidance on financial resources, and then provide counseling and help become the liaison between families and medical or hospital personnel. They help them cope with the stress after surgery, and they help resolve family conflicts. And sometimes they follow patients up to the home to check on how they're doing. The psychologist evaluates patients for the emotional well-being and offer the necessary support as needed, both to the family and the child. One of the sad stories we had recently was a parent who came to us and said that the child wanted to drop out of school because there was too much teasing. And we had overlooked completely the emotional toll on this child of the cleft. But something is we're trying to do something for this child. Oh, this is not advancing. Now, audiologists has to check for hearing. Without hearing, you can't talk, and you can't learn. So they do the hearing assessment and collaborate with the ENT surgeons who may put in ventilatory tubes to improve the middle ear and relieve effusions. Nurses, what can we do without them? They play multiple roles and in communicating with families, working to ensure the patients are comfortable both at the outpatient and inpatients, organizing their records, and so on and so forth. And they know a lot, and you cannot do without nurses. Now, sometimes the coordinator may be a nurse, or could be a specially appointed person, but you need a coordinator to arrange appointments, keep records, and monitor interactions, and to just deal with any communication between the health personnel and others as the need will arise. Sometimes you need other specialists, especially some of the extensive craniofacial conditions, neurosurgeons, ophthalmologists, and others may be needed to help manage, to evaluate the patient and also manage the patient. Now, parents and children, you know, they know a lot more about themselves than we would like to believe, and so they cannot be left out. We must constantly confer with them, consult with them on how they're feeling. Something we don't do a lot of because often we see them, sit them down, examine them, and then we're in such a hurry to go. But we need to make more time to hear from them. They bear responsibility for our interventions, and whether they will take a treatment or not, it depends on how we treat them. Now, I just want to share an example, our own experience with multidisciplinary team care. Our team started in 2003. We started with weekly clinics, and we started with a small group comprising maxillofacial surgeons, plastic surgeons, pediatrics, child health, and speech and nursing. We had dental. Now, along the way, we realized that many patients could not come back for visits, so we needed to have money to help them. So we set up a foundation in 2007 to try and raise additional money to support them in that respect, so they could be coming back for visits and be supported in other ways. I must say that at that time, we also signed up with Smile Train, who was supporting surgeries. But we needed more money to do other things. Sometimes we would admit a patient on the ward for even a month. Our pediatrician would recommend it to be fed and made fit for surgery because they were so undernourished. And so that needed money that would come from elsewhere. So we set up this foundation, which has been the backbone, and Smile Train has been with us as such all these years. Now, currently, this is the composition of our team. We are many. We have pediatrics, nutrition, speech therapy, orthodontics is now on. We never had before in the early years. And then we have dental as well. And then nursing. The nurse is the one who coordinates it. We have the surgeons. We have OMFS, plastic, and ENTs. We're currently added a neurosurgeon because we're doing craniofacial work. Social worker joined us in 2011, and he made a fantastic difference. A health educator helps to coordinate our parent support group and most of our education activities. And then we have a geneticist who works with us now, one of our own who did a PhD and joined us. And they have a data manager. Oh, God. Sorry, guys. Okay, so this is our team in the early years. This is our pediatrician, one of our surgeons, another surgeon. This is our speech pathologist in the early years, one of our surgeons, some nurses. And at the moment, well, our clinic is, popular with students, so the students are rostered to appear on our clinic. This is our clinic in 2020 when we were visited by some familiar faces, including the CEO of Smile Train. We had a visiting surgeon who was here to just improve on the skills. And so now, over the years, we've also we also trained others. We're partnered with Seattle to train others in team care. And so this is one of our such meetings, took place in 2017. We have it in collaboration with Nigeria and Ethiopia. And we've trained people from many different African countries, Senegal, Ivory Coast, Tanzania, etc., etc. And one of the big things that our social worker introduced was home visits. These are our nurse on a home visit to a family. There's a child whose lip was repaired, and the mother and relatives, and this is the same child. And the social worker himself and one of our nurses visited a village with another social worker to see a child with a cleft repair. Now, a social worker and our health educator also helped us to do this parent support group, which meets about 3 to 4 times a year, where parents give us feedback on how they're doing. Now, one of the best things is every end of year we had a party for the children. And here you can see the children dancing. They get their faces painted and engage in a lot of fun. Dancing competitions. This guy really has the moves. And the dancing is not only by the parents also. There's the kind of the musical chairs. They're dancing, trying to beat each other. The dancing is our pediatrician. There's a visiting one of our trainees who came from Burkina Faso, who was there when we were having it, and he also enjoyed himself there. Now, how do we move forward? I think we need, how do we build teams? We need flexibility from our funders so that they will be able to authorize the teams that are in existence to offer more treatment options and so that we can expand. But beyond that, we should also look for additional resources ourselves so that we can support and add to what our funders are given. We have to tap into what the country has to offer and what philanthropy in general has to offer. Smart Train is fantastic, and we should really supplement what Smart Train is doing so that we can even help a lot more. We need to promote team cleft care across the sub-region and let it be the standard. I think it's important for all those who are doing cleft to understand that even though they may be doing things, there's something higher to aspire to. That is team-based cleft care. And so they work towards that. The public that we deal with must be educated to expect more from a cleft service. They should not be just happy with us appearing in the village one day, rounding them up and then closing all the gaps and then leaving them there. They should expect that we offer more in the area of speech, in the area of orthodontics, in the area of any other problem that they may have. We should also offer training of the needed expertise to help us to build teams. So we have to invest in training. We have to, the personnel we don't have will not just appear from anywhere. We have to train them. And so we will need to do that. And that's why we need additional resources. Some of the training could be long-term training, others can be short-term training. But Smart Train has been very good with a lot of the trainings, but some of them we may also have to do, especially for the very long-term trainings that are needed. If you want someone to come out with a speech therapy degree, you must train them. I'll say that one thing we need is humility as practitioners. Humility to admit that what we are doing is not perfect and we could do better. It is always nice when your colleagues pull you aside and say, oh, you know what, couldn't we be doing this way? Sometimes they are so nice about it. And it's a way of saying, oh, I think we are not doing this and we should be doing it. If we shouldn't worry about not having personnel, we should always start small. Start with the few people you have, 2, 3. You don't have to wait to have a full complement of staff, but you must aspire to have a full complement of staff on your team. Very important, but start small and start today. I have one slide, I think, and I'll share it. And this screen share. Yeah, so to conclude, so the cleft craniofacial team is a means of organizing complex multi-specialty care in a humanistic and cost-effective manner. And the team approach helps to reduce cost, minimizes school and work time loss, and promotes a more comprehensive view of care. It implies that quality review on a continuous basis. I mean, if you are working with your colleagues who are looking into your work, many times my pediatrician and others see the work, oh, Prof, as for this work, the lip doesn't look nice. And they are honest about it. And they are looking at your work. And so there's peer review on a continuous basis, and it helps you to improve. And in order for us to construct good, effective teams, we have to be desirous of enjoying the bonding that goes with team building and having satisfied parents and families. Oh, the next slide, which doesn't want to come, I think, is saying, thank you, but I'll show it. Thank you. Thank you very much. I've survived the technological hitches. Over to you, Mr. Moderator.
Peter, thank you very much for that talk. And I think you've delivered it in good time. We have a few questions and comments, and I think we can still send in our questions via chat. We may have time to take a few more. Let me just take the ones I have. Saidu is asking, at the beginning of your talk, you mentioned that cleft patients have like a 14-year lower lifespan. He's wondering, is that for those who have been treated surgically or those who are untreated? That's the first question. Then Francis is asking from the psychosocial angle, based on your personal experience on the involvement of social workers or clinical psychologists, how have you coped with that, especially in our resource-limited settings, and has it been effective? I want to chip in my own question at this time to say, all the various teams we have, doesn't it add more logistic burden on the families coming for multiple visits? How do we coordinate them? Then Timothy likes the idea of the get-together end-of-year party. Maybe he's thinking of doing that in the center too. Olutayo is asking specifically, what criteria do you use to select team members? And then finally, before we move on, Abiodun wants to know, how are conflicts managed among the teams, especially the surgical specialties? I will just take them quickly. 14-year lifespan, for those who have been treated or not treated, they want to know. What's your experience in involvement of social workers, clinical psychologists, especially in our environment with limited resources? And what criteria, what's the basis for selecting team members? And how do we manage conflicts among team members?
Okay, so thank you very much, Philip. Well, I think in general, I think it's considered that the stress of the cleft condition is what probably accounts for the shorter lifespan, rather than because even the ones who have, of course, if it's repaired early, and the child can look as normal as possible and speak as normal as possible, then the stresses on them are markedly reduced. But a lot of cleft patients live with a scar of what has been done to them. They have very little social support, and so that is what is considered to be account for that. So the challenge for us is, how do we improve our act so that we can give them the best care possible? I mean, we've seen many who, after having had a nice lip repair, they come back and their teeth are messy because nobody even thought that they need to have any dental care. We've had others who they look good on the outside, but their speech, that people, well, this person is funny because, like, why do they speak so badly? And so these are the reasons why I think it's all just the general poor quality of care that may also contribute to that. So now on the social workers, our experience has been very positive. In fact, I would say that when our social worker joined us in the year 2011, without any exaggeration, it was one of the most one of the best things that happened to our clinic, because we did not even know how to deal with the difficulties that the patients had outside the clinic, in their homes, in the communities. But the social worker knew how to engage with them there. He knew how to link them up with sources of funding. He knew how to link them up with even just the local authorities and things like that. And so he made a big difference. And I'll say that he enlightened us, and we have a great relationship with him. A very unassuming young man, and he's grown and grown and grown, and he's becoming more and more central to our operations. So I think now we don't have a psychologist, I must say, but we have a social worker. So we are short. We don't have a psychologist. We need to get a psychologist from elsewhere to help with our patients. So that's what I should say. Now, the burden of care with all these specialists, the ideal situation is to have all the specialists, and that is what really happens in our case. We will try to get a specialist in one room during the visit. So the child comes, we meet around them in one room, and then in one room, the surgeon may assess them and determine the nature of the deformity. Nutritionists may pull them to aside and advise them on feeding. Pediatrician will do a total body examination and determine that there's nothing else wrong with them, or there's a problem that needs assessing, or they have malaria that needs to be treated. Speech will come and do an examination. And so in that one visit, that child sees everybody, and of course the orthodontist will be there. Now, subsequently, we plan out their treatment so that they may need to visit each of the specialists at different times. So that now you think that the major problem is orthodontic, then they may spend their next visits coming to see the orthodontist outside the clinic. If the major problem is speech, then they spend most of their time seeing the speech. If it's surgical, of course, the surgeon, and so on and so forth. So but the initial assessment and treatment planning is done in a group, and the treatments are then. But of course, the burden of care is heavy. A lot of financial cost to the children. If there's insurance, that is great. If there's an insurance, then they have to bear it. But now with Smile Train coming in some cases they offer grants for travel, so that helps to relieve the children of this burden of travel and the parents. So you're right, the burden of care is not lessened, but it is minimized. It's not stopped completely, but it's minimized. Now, how do you select a team? Well, I think at the very least, a team must have a surgeon. A team must have, if you have a pediatrician, have one, or a primary care physician. A team must have a dentally qualified person like orthodontist or dentist. A team must have a speech therapist. These are a basic minimum. And then as you grow, you can add on others based on the interest. Now, individuals would normally show interest, and it's based on their interest. Some people are not interested, but oftentimes you'll be amazed of how interested they are unless once you approach them. So I think that's how you build a team. Conflicts, how do you resolve conflicts? I think it's always very difficult to resolve conflicts. But in life, there's also what is called reality checks. I mean, and a case in point, for instance, I was telling about the peer review. We have had cases where maybe even our non-surgical colleagues will have the benefit of reviewing cases that we have operated upon. And they are able to comment in a group setting as to what they thought the quality was. And so they'll say, maybe I'm trying to repair a pallet and it's not going so well. They will say, but why is it that all these pallets that I'm repairing are gaping? I mean, that is one way. But the other way generally is to sit down with the team members individually, not in a group, and find out what their problem is and find out what their strengths are, because there's a whole range of procedures that need to be done: lip repair, palate repair, nose revision, available bone grafting, and then maybe orthodontic surgery. Find out what they are capable of doing, and then let them are most comfortable with, and then encourage them to stick with what they are most comfortable with for the sake of the patients. So, we've never stopped anyone from participating in the clinic. We had maxillofacial surgeons and plastic surgeons doing most of the primary work. The ENTs in our center don't do a lot of primary cleft work, but they help with other ENT procedures. I think those are the questions I had. Thank you.
Thank you very much, Peter, for those responses. We have a second batch of questions, and I think that may be the last for the day. I will just take them slowly so you can jot them down. One is an interesting one, that how is speech assessed at 6 months? As a question, how is speech assessed at 6 months? And then somebody spoke about cleft registries that we have for cancer registries. Do we have anything in the offing? How would that be coordinated? Because data drives almost everything we do, including finances. So any experience with cleft registries? And you mentioned the flexibility of using funds in determining who and how we bring up members into the team. Somebody thinks that is very good because different countries have different rules and settings, and therefore our funders should be very flexible in how groups and partners spend their resources. A very tough question here. How do we get Ministry of Health involved in Smile Train program? First, how do we get them involved, and how do we sustain them involved long term? That's a question I think is quite interesting. One quickly about Ministry of Health too. Considering COVID-19, how do we change how the Ministry of Health look at other problems that we have? I would want to add here that in this our lecture series, there's something on COVID-19, so I think we should also tune in for that. I don't think I've left out any questions that are pending. After this batch, I think we can call it to wrap it up. Peter.
Okay, so speech assessment is to at 6 months, or even at 9 months, or even at 1 year or 12 months, is to see whether the child is making any effort of making any sounds, babbling. In the early part of speech assessment, to see whether they are babbling, because that's how children do. They try to make sounds, trying to just, and that's all. The speech pathologist. Unfortunately, there's a talk in this series on speech therapy. So I don't pretend to be a speech therapist, but I know that they do assess to see whether the child is making a natural effort to form sounds. That is what they do at that early age. Now, when it comes to speech training, that cannot happen until the child is cooperative. And normally my speech therapist says that starts at 3 years upwards. Now, cleft registries, that is a very good question. I think what has been happening now is that you have individual clinics keeping their own data. But what we need to do is to have like national type cleft registries where all cleft beds are captured. And this is something that, we don't have in Ghana, but we need to work with the Ministry of Health to develop. Ministry of Health in my hospital, all data is captured electronically. And so what the Ministry of Health is now doing is to make all hospitals have e-capture of all data. And so we need to just work with them to see how data on cleft can be accurately recorded and accessed as and when needed. So that is a conversation that we have to have. I think the Ministry of Health involvement, I've always said is that You know, we should be so grateful for Smile Train and what they've done in our part of the world. Now, there is a saying in my language that if your jaw is dropping off, and then someone offers to bring a string to hold it up, and then you say, you hurry up, otherwise I'll just stop holding it. I'll let it drop. That's your problem. I mean, Smile Train has been so good in helping us to kickstart these cleft services. The next challenge for us, and this is where we must seize our responsibility, is for us to let our ministries of health recognize that it is their responsibility to see cleft no differently from any other medical condition that we as health professionals have to deal with, including malaria, COVID-19, and any of these hernias and other things. So it is our job. We have to be the advocates, because we are the ones who understand the condition. We are dealing with children whose main problem is a deformity. Once we're able to fix it, they can go and function normally and be economically productive. So we have to do that. And I think we have to see that Smile Train is giving us a push. And the next thing is for us to do even more for ourselves. In the light of COVID-19, you know, COVID-19 is going to pass. And the Ministry of Health now is putting all its effort into that. And we are all part of the efforts at controlling and COVID-19 and keeping our population safe by doing all the right things. But we have to say that now as an emergency, when the time passes, we go back to how we used to manage our patients, and we go back to the things that we consider to be our priorities. So I would say that let's not be discouraged by the fact that it's not only cleft work that is being on hold because of COVID-19. Many elective procedures are on hold in my hospital. And so we will still be committed to what we do, and I'm sure we're going to do very well. Thank you very much.
Thank you very much, Peter, for those responses. I had said that was the last batch, but I can see we have 2 minutes more and we have 2 more questions. I hope you don't mind taking the 2 questions.
No.
Thank you very much. One question is, how do we close the gap in developing surgeons to be involved in orthodontic surgery so as to improve orthodontic management of cleft patients? That's one in 1 minute. The next one, I think we'll close with this. The question is, who should lead the cleft multidisciplinary team?
Okay, all right. Now, the gap in training of surgeons. I think one of the initiatives that is currently ongoing, which is the Wax Smile Train Partnership, is for me the most fantastic initiative which has happened in cleft for many, many years. First of all, different surgeons who are currently in practice have different skill sets. This program that is being launched, which is this initiative, is going to try and unify skills so that any surgeon who goes through that will come up with a composite set of skills, including, hopefully, skills in orthodontic surgery. Now, who's going to lead it? We will have to identify centers of excellence where surgeons can go for such training. Orthodontic surgery will not be needed by every cleft patient, be needed by some. So not every cleft surgeon needs to be competent in orthodontic surgery. But those who need it must be able to have a point identified center where these procedures are done and go for the training. I think that's a conversation that we can have as Wax Smile Train going forward. Who leads the cleft team? You know, anyone can lead a cleft team. Whoever leads it must be respected and regarded as a leader. The individual must have the temperament to be able to take in criticism and be as open as possible. It can be an orthodontist, it can be a speech therapist, but the individual must show commitment week by week to the work, and as much as possible must be available to not only the practitioners, but the patients and their families as well. So that is my answer to that. Thank you.
Peter, thank you very much once again for an excellent talk. There are a lot of messages saying thanks, good talk. I won't go into those. We also want to thank Smile Train for this initiative. We want to thank the West African College of Surgeons for sustaining this online teleclef series. I think we should all tune in for the next talk to be on Monday, 4th of May, same time, GMT +1. The topic is management of newborns with clefts during COVID-19. It promises to be very interesting. Thank you all.